When she turned, when she turned to sharp bend, she collided with a tree, and there were no other passenger involved. She was found in her severely damaged car, drowsy and restrained by a seatbelt and the dashboard. The car windscreen had a bull's eye on the driver's side, and she had laceration to her forehead, which was bleeding profusely. She complained difficulty in breathing, pain in the chest, abdomen, and obviously deformed right leg. The paramedic attended the scene with the fire service, who helped to extract her from the carward, then carefully embolized her cervical spine. She was immediately transported by helicopter to the nearest emergency department, and there she was treated by the duty surgical trauma team.
Okay, so you have just a multi-trauma, 19 years old, car accident. She's a driver, and she was restrained, I think, right? They said she was restrained. And
yes.
Right. So let's see what's the questions. Let's go with the first question.
First question, which of the following intervention should be performed by the paramedics as their initial management?
So like, going to see patient with a trauma, what the first thing you expect from paramedic to do?
Yes.
We know the protocol, right?
Yes.
The ABCD, right?
Yeah.
So A is what?
To maintain the airway.
Airways. B is breathing.
Breathing, yes. C, circulation. The disability and exposure.
Yes, both.
With airway, there is cervical spine protection.
Well, let's see which is first one. Is this your first priority?
No, airway is the first priority.
Okay. So this is sometimes could be multiple, but here they want what the most or the first thing you need to initiate the management. So reduction, go ahead.
Reduction, splinting, and embolization of her right femur fracture. B, intravenous cannulation and bolus of fluid administration. C, high flow oxygen administration. D, administration of analgesia.
So what's the first? What's the priority?
Airway, but look like patient, she can maintain her airway. So I think so B is the most appropriate answer with high flow oxygen administration.
You said ABC, right?
Yes.
So you said A is always fine. What about B?
Yeah, B, I'm with B, so I'll maintain the oxygenation of the patient, breathing.
Yeah. So B should be oxygenation. So the answer should be C.
Yes, high flow oxygenation administration.
Yeah, the oxygenation first, then C goes cannulation and give a fluid.
Yeah.
Okay. And then I think A, B, C, D can do reduction. Last thing can give analgesic. That's the way I put them in orders,
Yeah.
I think it's a straightforward question, not much to talk about it. So let's not waste our time here. Let's go to the next one, the same, continue.
Samer,
sorry, I told that. Yeah, please.
All of us know that the ABC, that we have to follow the ABC, but now our colleagues, anesthesiologists and intensive care units, they say that you have to begin with C, with the circulation. So you have to maintain a circulation, then you can go to the other steps. So for them, the circulation for the brain, it is the most important thing that you have to begin with. So they begin with C usually, and then we know that ABC, but now they begin with C, with the circulation as first attempt to for the patient. I don't know what is the answer now in this question after when we will see the answer, but our intensive care units colleagues, they say that circulation is the most important thing for them.
Okay, Ali. As far as I know, they did modification. Yeah, I agree, but not C. They put a B first, BACD. So they want the breathing. They don't.
Yeah, C as circulation.
Not the B answer. I mean the B that means breathing. You have to give it oxygen the first thing, then you look for the airway, and then you do intravenous. This is the only thing they change it, you know. But maybe some is more updated. But I one time in BLS and ACLS, now they said you do breathing, airway, then circulation. Before it used to be airway, breathing, then circulation. Now they just put the breathing first, because the most important to give the patient oxygen right away. This is the most important. Then you can worry about airway and then the intravenous. Isam, what do you think, Isam?
Yeah, Muhammad Ali Zaik, كيف حالك? It's the change. كيف حالك? The change that Muhammad Ali is referring to, C before ABCDE, is something we got from the Afghanistan war. And the C there, Muhammad Ali, means control of hemorrhage. So what you need to do is, if you attend polytrauma, if the patient is actively bleeding, you need to make attempts to control hemorrhage before you address ABCDE. So that's about applying a CAT tourniquet, a combat applied tourniquet. So in fact, we had a case, 16-year-old shot in the thigh, and he was in the ED, and he almost died of hemorrhage because nobody had bothered to put a tourniquet on him. So C there means control of hemorrhage. Ba'ad daka, the point about breathing, airway, it's about making sure the airway is clear and then putting oxygen tawali. But that's our interpretation of it. But the C there means control of hemorrhage. That's where I think your anesthetic colleagues are referring to. But let's see what these guys say here.
They put the answer, let me see here. They said ABC, yeah, they put B as the answer, which is, sorry, C, high flow oxygen administration. So they're still on the old fashioned, I think.
Yeah.
Even though this is like 2018, the book, but still, you know. So again, I mean, it's not very, it's not much with this question. So we'll not waste too much time. I think you need to do all of them. Okay, let's continue, Muhammad.
By the way, we have another fellow. If Muhammad wants to give somebody a chance, break later on.
Yeah, please. I wish there's nobody. I wish anybody can. Yes.
No.
Go ahead.
Dr. Faraz with us from KSMC.
Okay, go ahead.
Yeah. Maybe they can take turns doing question each. Yeah.
Okay. So let's take second question.
Yes. Hello.
Hello.
She's gonna hate me now, but there you go. Go on.
Not really. I just have a headache. I got the flu. That's all right. So the question says, which is the most appropriate initial investigation required?
No. Read the question. No, start from above, because this is a scenario. We have a scenario.
All right. I thought it was for the previous question. Primary examination is casualty revealed a patient. In casualty revealed a patient airway as patent airway. As she was talking, she was short of breath. Her trachea was deviated to the right side. The left chest was hyperresonant and devoid of breath sounds. Hemodynamically, her heart rate was raised 109 beats per minute, and blood pressure was 120/75 millimeter mercury. Was within normal limits. Her abdomen was tender in the left hypochondrium, and right femur had an open midshaft fracture. Routine trauma blood investigations were requested. Neurologically, she was drowsy and becoming increasingly confused. So the question is, which is the most appropriate initial investigation required? So now we have a
is she stable or not, Farah?
So she's just slightly tachycardiac. Blood pressure is maintained.
Right.
But they mentioned drowsiness and confusion. So
well, what do you think the reason for drowsiness and
yeah,
confusion?
it probably lost a large amount of blood because of that fracture of the big bone.
Or could be the abdomen, right? She has tender abdomen.
It's tender, yes.
Also, what's the problem with the
also
chest? What they said the chest also.
Yeah, she might be having a hemothorax or pneumothorax as her trachea is deviated to the right side.
So you have all the sources.
So it's pneumo, yeah.
Yeah, so you have a lot of sources, but still she's kind of hemodynamically stable. So at least we have some times to, do some testing, right? Because if she's hemodynamically unstable, what should we go? What should you do?
Well, if she's
her pressure like 80s, and she's like a 120, her blood pressure 120, her pressure is 80 over like 40, 50.
Yeah, and what about her GCS as well? Like, depending on the GCS, I would decide whether she needs to be intubated or not, and I have to resuscitate her if her blood pressure.
Okay, let's go with a scenario. Let's not go too fast. Let's go with a scenario. Okay, let's go as they said here. So in this scenario, what you do?
Sorry, Samer, let me just come here. You guys, in the previous thing, you said there was a bullseye on the windscreen driver's side. Do you guys know what that is, a bullseye on the windscreen driver's side?
Go ahead, Isam. I have no idea.
Yeah, that's where the patient smashes their head against the windscreen. So there's it looks like a dartboard. So the central smash, and then it cracks on the outside. So that suggests that she had a head injury. Although she was restrained, she smashed her head on the windscreen. Yeah? Okay.
So continue, Salah. So what do you do?
So
let's go question by question. First one. Let's go with first one.
So which is the most appropriate initial investigation required?
Yeah, let's have the first one. What about CT head and neck?
I mean, she is confused, and she did have a direct
what
trauma
the first thing you want? What is the first thing you're concerned now about her? What? The first thing you need all of them. There's no questions. But I'm saying they want you to do because you have a trauma. Time is important. They don't want you to waste time looking for like femur fracture where she's not breathing. So what the most important part?
I would get a plain chest radiograph.
Okay, because the most important is the breathing, right?
Yes.
We go back to the basic breathing. So the most important for us is the breathing. This is what our concern, right? So we want to be sure if she has what we're looking for with the chest X-ray.
The pneumothorax, if she has it, because all of these are telling me that she has a pneumothorax, or maybe she has fractured ribs, or she has hemothorax.
Okay, so you're looking for hemothorax. Anything else good? You're looking for chest X-ray? Tension pneumothorax, right? And the third thing, you can look for wide mediastinum, right? This is the whole thing we want to look when you do an X-ray, to look for trauma, right? So, so yes, CT is important, head and neck, but I don't think it'll be our priority. Pelvic and right femur, I don't think is a priority. CT, abdomen, and pelvic, yes, she will need it, but not now, not the first thing. So I think the first thing to do, chest X-ray, to see if she has hemothorax, tension pneumothorax, wide mediastinum, something to treat because she has difficulty breathing, and she has a trachea deviated to the right side. Okay?
Yes.
All right, let's continue that for now. You're already there. Let's continue with the question. So her life, let's see what happened now.
Her heart rate further increased 120 beats per minute, and blood pressure reduced to 110/65. She was visibly more confused, and breathing was more labored, whilst her abdomen had also become distended. Hemodynamically, she was a transient responder to a bolus intravenous fluid replacement. So now we have a...
Go ahead.
Yes, doctor.
No, go ahead.
She's dropping her blood pressure, and her confusion is becoming more prominent. It seems like definitely she has an injury to her intra-abdominal organs, as her abdomen is becoming more distended. The fact that she responded transiently to fluid replacement as well could be suggestive of the fact that she has an ongoing bleeding intra-abdominally.
I mean, I agree with the first part. You say ongoing bleeding, but why you keep consisting on abdomen? Why is it could be not the chest? Why not the thigh? I'm not saying they are not, but don't be specific. We don't know yet. The only thing we know that has hypovolemic shock.
Yeah.
Correct?
Yeah, definitely. But the thing is, because the one that's mentioned for us is that her abdomen is becoming more distended. Otherwise, they're not mentioning any worsening in her breathing or...
But remember, the chest X-ray, what we said, she has a shift, right? And she has a dullness. So she has something in the chest, right?
She actually has a hyperresonant chest, Doctor. Shifting of trachea, but hyperresonant chest.
Let me see here. Okay. Hyperrhythm could be a tension pneumothorax, right?
Yes.
Can tension hypothorax cause a hypovolemic shock?
Pneumo? No, not hypovolemic.
Hypovolemic shock.
No, tension
What
pneumothorax.
the tension pneumothorax can compress? What you have something can be compressed? The IVC, right?
Okay.
So the IVC can be compressed with the tension pneumothorax. So you can decrease the backflow to the heart, you know, so you can become hypotensive. So this is something you can put in your mind. I'm not saying that is the main cause, but something you can put in your mind. So, and then you have the abdomen could be a source of bleeding. Then you have the thigh, you know, and also we don't know what's you know, so we have to look at all the things. But we go back again. Our priority is what is our breathing, right?
Yes.
So, and now you have a trachea shaft in the trachea, as I said here, and you have hyper resonant and devoid of the breath sound, breath sound, you know. So it looks like we have a tension pneumothorax, right?
Yes.
So are you going to open her belly and with tension pneumothorax?
No. Open the what?
Debate about ventilator tension pneumothorax, you know. So I think we go back again. Our first priority here is a breathing, right?
Yes.
So what would be your we're number 3, right? So what would be your most immediate intervention now? Like laparotomy, reduction. Go ahead through all of them.
I would put a chest tube. It says chest drain insertion, emergency laparotomy, and damage control surgery, reduction, splinting, and immobilization of the right femur fracture, or diagnostic peritoneal lavage. The most one I feel it's appropriate is the chest drain insertion.
Okay.
Or chest
Do you know
tube.
what the damage control surgery? What they call damage control surgery. You know what that? You should have it, guys, in Shumaisi.
Yeah.
What is that
damage
mean
control
for people?
is basically opening the abdomen, packing all 4 quadrants, and to control the bleeding, close it, and then take the patient to another, or after 24 hours for to reassess the abdomen, open, remove the packs, and reassess where the bleeding is. Or we can do it at the same time in the on table, apply the packs, and then remove them one by one and assess where the bleeding source is. If I was able to clamp and leave the surgery and come back again, or like, for example, if I have let's say a bowel injury, I would resect and leave it in a resected, like resected without reconnecting it. And then the next day I would reassess the patient. So damage control depending on what exactly I'm finding intraoperatively. Damage control is doing the minimal I can do to remove the source of where the injury is.
I agree with that. You keep concentrating only in the abdomen. I know why you just keep concentrating on the abdomen. What about the legs? It's not about the damage control. Split the leg, but
yes,
stabilize the leg.
Including stabilization.
Yeah. Damage control is that, as you said, to control all parts, but just do the minimum to control the bleeding. But not only the abdomen, maybe it's the leg, maybe it's the chest. If you have a bleeding, you may have to open the chest. But so it's a multidiscipline. So she usually is like a vascular involved, general surgery, orthopedics, all involved in surgery to do damage control. I think I'll leave to Sam to talk more detail about that.
Sure. Okay. Right. So I agree with Thara. The thing that could kill this girl in 5 minutes is a tension pneumothorax. So that's the thing you're worried about the most. And with the hyperresonance, trachea shifted, whatever, portable chest X-ray, pneumothorax, you stick a needle or a chest tube in before you do anything else. So I would have said chest drain insertion. So if you come down to the next part, you've got, let's see if Mohammed is still there. Mohammed, do you want to read the next question? Yeah?
Yes, doctor.
Okay.
Okay. So,
by the way, damage control surgery refers to the cessation of hemorrhage and the prevention of soiling of the peritoneal cavity.
Yes.
So those are the two things that you do at damage control. You stop bleeding and you stop soiling and get out.
Okay. Chest imaging revealed a widened mediastinum and left tension pneumothorax. Immediate left chest needle decompression revealed a wash of air and that trachea centralized. Consequently, left chest drain was inserted. The patient was becoming more confused and combative with reducing Glasgow Coma Scale to 7. So was intubated and sedated. Initial blood result revealed low hemoglobin. However, her hemodynamic had returned to values within normal range, with continuous fluid infusion and whole body transfusion, plain pelvic radiograph and clinical examination were normal. So, which investigation? Yeah.
No, go ahead. Let's see what the X-ray. Let's see what the X-ray number 16. Here we are.
Yes.
What do you see?
Very wide in the mediastinum.
You can see your wide mediastinum.
Yes.
What else here? I know it's not very clear, really. It's the pneumothorax,
Pneumothorax,
I think it's before the chest. I don't see chest tube. I think it's before chest tube,
Yeah.
We did an X-ray, But again, I mean, if you become patient hypotensive, you don't need to wait for chest X-ray. As Sam said, you just put a needle, and then you do an X-ray. Unless if this one a needle, I know what is that here. Unless they put a needle and then send patient for X-ray. But don't send the patient with a tension pneumothorax to the X-ray if he has difficulty breathing, all the things. You can lose them on the table. So the minimum you put just a needle to decompress it, and then later on you can put a chest tube. Yeah. All right. Let's go to the question. What was number 4? Yeah, number 4. So what you do next? Let's first about Glasgow 7. When usually you intubate, Muhammad, do you know when we intubate the patient, what Glasgow level should be?
It depends if the patient started with hello.
Yeah, we can listen.
If the patient started with a normal Glasgow Coma Scale, then he dropped, or if he cannot maintain his airway, like 11, I remember, but I'm not sure about the number. 11 or down.
I think it's 8.
8, sorry, 8,
Yeah, 8 and below, then you have to intubate the patient. Yes, you have to intubate because you cannot keep,
breathing, So which investigation or treatment should be performed next?
All right, let's go through that.
So plain radiograph of right femur, then reduction, splinting, embolization of her right femur fracture.
You think this is now let's go one by one. What do you think about
Okay, this is important, but I don't think that is the next step. Immediate next. B, CT of head and neck, chest, abdomen, and pelvis.
Okay. Let's go to the C.
C, emergency laparotomy and damage control surgery. D, diagnostic angiography.
So the chance between the CT scan or emergency surgery or diagnostic angiogram or with the femur, you know?
Yes.
Is that hemodynamically stable or unstable?
They didn't write it now, but I think before he was.
Oh, but they said here before this question, they said she's stable, right? They said she's stabilized.
Yes. Yeah, the previous question was stabilized.
She is
and
transient response to bolus, and her blood pressure 110. She's the tachycardic 120, but she's not like crashing. You know? So when the patient is stable, I think you have a time to figure out what to do, right?
Yeah.
So next step will be which one? You're going to do plain X-ray to the femur?
Maybe CT. No, CT.
Yeah.
Because even the drop in Glasgow coma scale indicates that she might have a head injury. So I think I prefer CT before doing anything else.
Head, neck, chest, everything. They do from head to toe. And this is what usually is CT scan, very quick, you know. But if patient is pressure is low, what will be next step? Let's say her blood pressure like 80.
Yeah, I'll stabilize the femur fracture and put her in traction to prevent No, if it's unstable, I will take her for laparotomy for sure. If the abdomen is the source. Yeah.
We don't know, but she's tender, so you don't know. But it's better to open and, you know.
Yeah, before
but
you lost
90%, but there's a drop and chest, there's no blood in the chest, right? There's no blood in the chest, right?
No blood in the chest.
So where's the blood? It should be in the abdomen. And the femur, you bleed, but you can see it. But she continued to bleed, you have to think about the abdomen. And this one, I think you don't need any images, just go straight to the laparotomy. Damage control surgery, as we said, you know. So I think this will be answers. And if anybody you have a question, anybody want to add anything? Look straightforward. Okay, Bassam, you want to come in, Bassam?
أهلا دكتور يعطيك العافية. السلام عليكم everybody. طيب, imaging revealed that she had suffered from polytraumatic injuries. She had bilateral cerebral contusions, left clavicle and cervical vertebrae fractures, multiple rib fractures, including the left first rib with a left pneumothorax and bilateral lung contusions. Her thoracic aorta was disrupted and a pseudoaneurysm of the proximal ascending vessel had formed. Her abdominal...
Let's see the images here. This is a femur with a fracture. The vertebral fracture is here, okay? Yeah. What they said also, they have a deformed vessel here. This is a trauma here, you can see it.
Yeah.
And then I think they have another image. Where is that? They said this one on 64. This one, you see that?
16.
What is that? What, you know, what the grade is this one? We have 4 grade, right, Bassam?
Yeah.
Grade 1, 2, 3, and 4. So this will be which one?
It's not
1.
Clear.
Okay, let's go with 1. 1 is what? 1 is a tear, right? It's just a small tear.
So this is not 1, definitely.
B is just a small hematoma, right?
Yeah, even though it's not.
3 is disruption with a pseudoaneurysm.
Yeah.
And 4 is a free rupture.
Yeah. So this one, stage 3, grade 3.
Yeah, this is stage 3 because it is looks like a pseudoaneurysm here, you know. Disruption. It doesn't look like a free fracture because it didn't have like huge hemothorax. You know, she has some hemothorax, but pneumohemothorax, most of it from the lung contusion, or could be from a trauma, but it's not like a free ruptures. All right, so let's see. So we talk about level 3 trauma, grade 3. So let's say what the other question they're saying here. All right, so her abdomen image revealed liver laceration. Continue.
Yeah. Her abdominal imaging revealed a liver laceration, large splenic hematoma, and free abdominal fluid suggestive of bleeding. Her pelvis was normal, but she had an open displaced fracture of her right femoral shaft. Clinically, she was becoming increasing more difficult to ventilate and was deteriorating hemodynamically. Her left chest drain continued to swing and bubble. However, blood was also still draining. Her abdomen had become more distended. She was in hypovolemic shock and was no longer responding to intravenous fluid and blood administration. Her right thigh wound was becoming more tense and swollen.
Okay.
An arterial blood gas revealed that she was suffering a metabolic acidosis with raised lactate, and her hemoglobin level had further dropped. She was taken immediately to the operating room. She underwent an emergency laparotomy, splenectomy, and packing of her liver. Her right femoral shaft fracture was debrided, irrigated, reduced, then immobilized with a splint. An intracranial bolt was inserted for pressure measurement. The duty vascular surgeon was called to assess her transected aorta, thoracic aorta. He scrutinized the CT chest imaging.
Okay. They call you for a consultation.
Using
let's Samer.
Yeah, up here. Yeah, it's a lot of things.
Let's just
I don't
go
know
back.
if they give us the answer. No, they will not give us the answer. Yeah.
There's a lot there. Let's just go back and pause on this here. Let's go back to her deterioration. The top there, right? So she became more difficult to ventilate, and she started deteriorating. Her left chest tube was swinging and bubble. However, there was blood draining. Her abdomen became more distended. So she's bleeding now, isn't she? There are three killers in trauma, and she's starting to develop them, isn't she? One is metabolic acidosis. The other is hypothermia, and the third is coagulopathy. They call the triad of death. So once you start to get to that situation, you know that she's bleeding a lot. So you need to explore her abdomen. You've got chest x-rays and CTs that don't show that much of a hemothorax. So this is coming from the abdomen. Yeah? Bassam?
Yes, sir, yes.
Okay, so the damage limitation is spleen in the bucket, pack the liver. Stop the bleeding. Also reducing the femoral fracture is important. That helps to reduce the bleeding as well.
Sure.
So, and then at the same time, you will need to continue to resuscitate her. She will need to receive blood. Now, are you familiar with something called the massive transfusion protocol?
Yeah, we have it.
So tell us about the MTP, or massive transfusion policy. What is that? How would you resuscitate?
Usually, if the patient in this situation, we activate the massive transfusion. If he needs more than probably 4 to 6 units, then we activate this code. And yeah, through central line, we should insert central line and start transfusing probably 2 units of packed RBCs, platelets, and fresh frozen plasma, sometimes cryoprecipitate. Yeah.
Okay. The MTP is something that you guys should all know. Again, this evidence has come from wartime. We now know that, and remember what I said to you about preventing coagulopathy. What are the triggers? When do you trigger the MTP? And what is the MTP? And it's the 1-to-1-to-1 rule. Yeah. So for every bag of blood you give an FFP, you give a pack of platelets. And you keep going through. Now, the normal MTP pack should have 6 units of blood, 6 units of FFP, and 2 platelets, which is 4 each. Sometimes here, because of blood shortages, they'll give you 4. So it should be, you are replacing blood, FFP, and then platelets. You don't go to the cryo until you go to the second round and you've got coagulation tests. Yeah, by that stage, you'll have a hematologist on board.
But
So
I saw in the VESAP transfusion, do you give just, you don't wait for time and cross, you just give 0, right? Or not, I'm wrong?
Yeah, the first pack you will just activate, they'll send you a negative. Yeah. So you ring and say, I'm activating the MTP, I'm Dr. So-and-so, this is the patient's number, this is where they are. They'll say, send somebody over. When you run over there, you'll take with you 2 20 ml samples of blood. They'll give you the first pack and they'll take the blood from you. When you come for the second pack, they will have cross-matched the blood. So by then you'll get group-specific or cross-match blood. It takes them about 30 minutes to cross-match. Again, the first pack is O negative. Yeah. So that's really important. Yeah. Now you've packed, you've opened, you've packed, and you've taken the spleen out, and now you've been asked to look at the aorta. This is a very common scenario that we get at KSMC. We see it about maybe 10 times a year. So, do you want to go on to the next thing?
No, let me ask this question, Hassan. Let's make it more difficult. What if she has, there's a fellow to VESAP or anybody, what if she has a hemothorax? She has like the whole chest hemothorax and bleeding from the abdomen. What you do? Which one you open first? Like, I mean, you just putting blood, chest tube, just putting blood.
Chest tube, and it drains immediately 500 cc of blood. Then
and you have the abdomen also bleeding. And you have distended abdomen and and you have hemoperitoneum.
If chest drains more than 500 cc or more, then the patient needs thoracotomy. At the same time, if there is any sign of abdominal distension or abdominal bleeding, then also
you have them both.
Yeah.
You have injured spleen, you have liver laceration, bleeding from the spleen, and you have hemothorax. It could happen. It could happen from a trauma.
Yeah, we do thoracotomy first because hemothorax will affect the blood return and the heart. So if you do the laparotomy first, he will not improve. So thoracotomy is the priority.
Because of the pressure. If you worry about the pressure, you have a chest tube. It will not be a pressure to prevent. If you worry about only that this can compress IVC, I mean, you already have a chest tube, so it's not your issue. If you only concern you have.
Yeah.
Yeah, but Sam, if you crack the chest every time you got 500 mils out, you'd be opening a lot of chests, my friend, unnecessarily.
More than lethal, correct?
Yeah. So I think you need to also understand the mechanism of injury. If you've got, so if you're opening the chest, how would you open the chest? What would be, assuming you didn't have a CT, what would be your thoracotomy?
Through the 5th intercostal space.
Yeah, you do a clam thoracotomy, so you can open, you can get to both sides if you didn't have a CT. If you didn't know. Yeah. Okay, it's called a clam thoracotomy.
Yeah, I agree with you, Sam. You open first the chest. Not only you can evacuate, you can clamp the aorta, and this will help you also to control the bleeding. and then you go to the abdomen. So yes, and you go this anterior, you crack the chest anterior, and then sometimes you can open chest and abdomen both, you know.
Yeah.
But I will open the chest first, clamp the aorta, damage control, go to the abdomen and do damage control, yes.
Okay.
All right.
I see there's a
Yeah.
very active member of this group called Ahmed Farid Rodwan, who's really keen to join. So let's give him a whirl.
Here?
Ahmed Farid.
Yeah.
Yeah. Ahmed Farid,
Come
are you
on.
there?
So we didn't go through the options.
Yeah, let's go through the options then.
Okay. So this one, they tell you, I know it's very important. They just show you the diaphragm here, which the consists. It's not important, this one. Let's miss it. I mean, they said which one is first, the ascending, descending. Nothing is unimportant. Let's continue with our scenario here with question 6.
No. Let's go back to that. No, Samer. That's very
This
important.
one?
Yeah, this one's very important. So they're asking,
so let me show
what is the question?
Picture. Which is the correct order of commenced anatomical site of traumatic aortic disruption, starting with the most frequent to the least frequent in the descending order. This is a picture here. What the most common place.
Okay.
I want you in orders.
So this is the site of blunt thoracic aortic injury.
For me or for Dr. Ahmed Farid?
For anybody. For you. Let's go for you.
Yeah.
I know that 3 is the most common at the isthmus.
Okay.
Right.
I assume then 4, then 2, then 1.
Okay. Nice. Thank you, Esma. As I would say, tutu. Thank you for playing. Okay. 3 is the most common one. Why is 3 the most common one, Ahmed?
The isthmus is the fixed portion of the aorta. So after injury, the fixed part of the aorta is the most common to be injured.
What is the mechanism of injury or the theories? There are 2 theories, but what is the mechanism of injury that always most commonly will give it to at the isthmus? What is the isthmus? What is the embryological origin of the isthmus?
I don't know. It's I know it's fixed by the ligamentum. Sorry, what's the name?
Arteriosum.
Arteriosum, yes. And the deceleration and the deceleration injury makes it fixed to the chest wall and make it more prone to injury. But I don't know the theory.
Okay, so the ligamentum arteriosum is the fibrotic remnant of the ductus arteriosum, connecting the aorta to the pulmonary artery, yeah? So that closes and becomes a ligament. Now, the heart and the ascending aorta are mobile within the chest, okay? They're suspended and quite free. The descending thoracic aorta becomes fixed beyond the point of the ligamentum arteriosum or the isthmus. So what happens is they think you get a rapid deceleration where the heart and the ascending aorta and the arch move while the descending aorta remains fixed against the back. And that's where the tear happens at that site most commonly. It is very, very predictable. We see it a lot. There's another theory which is called the water hammer theory, where they think the heart contracts against as it's twisting. So after 3, what's the next commonest site, Bassam?
I'm not sure actually, but maybe it's 1.
It's 1, yeah, it's 1. And that's usually due to direct sternal crush, yeah?
Yeah.
Yeah. And then after that?
Then 2, then 4.
Yeah. So it's 3, 1, 2, 4. That's what I would put. Does anybody disagree with that?
Three, 1,
2, 4.
2. Yeah, 3, 1, 2, 4. That's correct.
3, 1. Yeah.
All right. So let's go to question next one. Let's waste time on this one. So now let's see who is that now. We go back to Farid. You didn't answer, Farid. Let's go with Ahmed Farid. Or
which of the following? Yes, sir. Which of the following is a favorable feature for thoracic endovascular aortic stent graft access?
Okay.
A. Tortuous iliac arteries. B. Iliac
No,
diameter.
it's correct or wrong? Let's go by one. It's correct or wrong?
It's dependent. If it's very tortuous, it cannot be a good access.
Okay, so it's wrong.
Okay, iliac diameter more than 7 millimeters. That's I think.
Hello. Iliac diameter should be at least what?
Suitable for conduit formation. That's a good answer. Patent femoral arteries, if it is caliber can stand T-verb procedures. Calcified iliac arteries, if I think if it's circumferential calcification, it will be harder to be cannulated.
So what is your answer?
I think B is good. And B and C.
B and C, iliac diameter less than 7, not more. This is less.
Less. Sorry. Of course, C. C is the answer.
Sorry, C and you can have more than one answer.
C, D, if the femoral is good enough, if beta is
Yes.
caliber is good enough.
What the minimum diameter you want the iliac?
8 millimeters.
Why 8?
To accommodate the French caliber of the device.
What the average French for thoracic stent?
24 to 24.
20 to 24 usually. So how do you know how we convert French to millimeter?
Dividing by 3. 24 by 3 is 8.
3 by 3, yeah. So usually you need at least 7.6 to 8 or 9. So roughly you need an 8. But two things you have to remember in this situation. What you have to remember? Two things.
Let's ask Farah to answer that.
Okay,
what
let's
are the two things you need to remember in this situation? The traumatic aortic injury in a 19-year-old who's come into hospital with multiple injuries.
You mean in regards to access?
In regards to access, in regards to iliac diameter.
Like, let's say this guy has 7 millimeters. You think he's not candidate for TVAR? He came, he's in hypovolemic shock with a CT scan, and now we found this injury. We want to do a TVAR. We measure his iliac is 7 millimeters. And they said here you need at least 8 millimeters. So should we exclude him? And why not?
Well, there's always chance to create an iliac conduit.
Would you go with a conduit right away, or you think you'll be able to get the device in with a 7 millimeter?
Have you ever seen us create a conduit for a trauma case?
No.
No.
Don't do it. Patient hypovolemic shock, right, Tara? What does that mean, hypovolemic shock? What does that mean? That means the artery are what?
Smaller.
Smaller, correct? So they are because of vasospasm,
And spasm,
correct?
yeah.
And the volume is low. So what the measure, what you see is not correct. So what you see 7 could be 8 or 9. You see, this is what I tried to say. So when the patient is hypovolemic and you do CAT scan, you cannot rely only on that, unless if you do it after you restate the patient, he was blood pressure fine, but this usually it's not the scenario. Scenario patient come hypovolemic hypotension, you do start CAT scan. So you have to be careful. Even when you measure the aorta to do a TVAR, you have to be careful. Remember, this is hypovolemic patients, so your size will be always undersized. That's what happened with this trauma. We always end undersizing the aorta. And the second thing, this is patients that are young, 19 years old, not old. So the arteries, they dilate usually. They are soft, no calcification, not like I'm talking about 80, 90 years patient with a trauma. So young people, they have tendency to dilate their arteries, So don't make this one exclude you from doing the TVAR for this kind of patient, But in his exam, the diameter you need at least 8 or 7.5 to 8 at least, you know, to get the T-bar device.
Okay.
All right, nothing to add. Let's continue with that. So mostly going to the T-bar blocks. We go back to you. Anybody else? Muhammad?
Okay, doctor.
Muhammad, are you still there?
Yes,
Yeah.
yes, doctor. Which of the following is favorable feature for TVAR deployment?
Okay.
A bovine aortic arch. B, aortic
Let's
diameter.
go one by one. Let's go
Okay.
one by one. Muhammad.
Yes.
What about bovine aortic arch? Is it good or bad?
It's not. No, it's actually not good, because with the bovine arch, you might close both carotid and subclavian if you want to close subclavian. So it's not favorable feature.
What is
common?
What is a bovine arch?
It's type of aortic arch anomaly that is you can see the takeoff of subclavian and carotid in the left side is coming from one branch.
Never seen that in my life.
No, so maybe I failed describing it.
No, you described it accurately, but maybe you mean something else.
Right.
Yeah, it's common. Yeah, it's the left carotid artery coming from the right. Sorry, and the subclavian is alone.
So, what is the first branch of the arch in a normal
subclavian? No, not the subclavian. Brachiocephalic. Sorry, brachiocephalic giving right and left subclavian and aortic. Then we'll get one left common carotid. Then left subclavian.
Okay, so what is the commonest type of bovine anomaly? There are many, but what is the commonest kind?
The commonest type when all came from the 3 branch coming from the right side and left subclavian coming along.
Okay, so that means that you got brachiocephalic and left carotid coming off together. Then you have a huge landing zone, and then you have the left subclavian artery.
Yeah.
So is it a favorable feature or is it not if you are in a trauma situation?
It's not favorable feature, although they associate it with a lot of aortic trauma, aortic they might be related to.
We love it. We love it because it means that we have a nice long landing zone. We almost inevitably cover the left subclavian. We don't have to worry how far the left carotid is. And so it gives us a good landing zone.
Yeah, but the problem if the patient is dependent on this left subclavian and you want to do carotid subclavian bypass, you will have a problem with the clamping this arch, like this branch.
Muhammad, you are confusing things.
Sorry, no. Let me walk him through his thinking, Samer. So how would this is how the exam would go. So how would a carotid subclavian be difficult if I have to do it? Does it matter where the left carotid is arising from? I'm operating in the neck, not in the chest.
Yeah. Sorry. Yeah. I'm confusing things. Yeah.
Okay.
It will be the same carotid because you will clamp the left only, and has no related to the takeoff. Yeah.
Okay.
So yeah.
So going back to Ahmed Farid's point about the commonest site being at the aortic isthmus, which is just a little bit further beyond the left subclavian, in order to get a good landing zone, and in the exam, you'll be asked what is the acceptable landing zone.
Yes.
And you would say how much?
You need at least 2 centimeters.
2 centimeters.
Yeah.
Now, these young trauma patients, you can get away with less, and you'll often see people getting away with less. But most of the time, you will have to cover the left subclavian. Okay? Now, in a trauma situation, are you obliged to revascularize the left subclavian?
No.
No, doctor.
No. So the guidelines will say that you don't need to. We do.
Yeah.
We at KSMC, if we find an indication for revascularizing the left subclavian, maybe Samer can take over and ask somebody else what the indications are for revascularizing the left subclavian. Samer, do you want to do that?
Yeah, go ahead. Anybody can answer. What scenario we have if we cover subclavian? Some people, as Sam said, always they do subclavian bypass. Some people they do selectively. So if we say selectively, what are the scenario?
So either pre-op or post-op. Post-op, the most common indication either left upper limb ischemia or Steele syndrome due to dominant vertebra on that side.
Right.
So
but I'm saying before surgery, like you look at the CT, you look at the patient, said, okay, this patient I'm going to do subclavian simultaneously with TEVAR.
Yeah. So you
what's
see
the scenario
then
you prefer to have, or you have to do a subclavian bypass?
a left dominant vertebral artery with hypoplastic right side. This is usually the most one of the most common scenarios.
What else?
And you.
What do you have as a cabbage?
Post-cabbage patient, depending on lima.
If you had a lima.
Yeah.
Right. What else? I mean, it's not relative.
Any situation.
Sorry?
In trauma situation or in ordinary TEVAR?
In trauma, we're talking about in trauma.
It's unlikely to be a traumatized patient with the same side arteriovenous fistula, but it's an indication.
Yeah.
No, what I'm saying is that if patient has his dialysis patient has AV access in his left arm, had a trauma, and you have to cover subclavian, it's a relative, indicate to cause subclavian bypass to keep his access open. But it's not, I think, it's not like absolute. Like if you have as Muhammad said, like dominant vertebra on the left or the limma. What the other indications? If the vertebra coming from the arch, then it's better to cut subclavian bypass.
Spinal cord susceptible to injury or ischemia. Previous patient who had previous EVAR or a problem with hypogastric arteries.
This is correct, but this is if you talk about aneurysm or dissection, chronic situation where you have to cover like 200 or more. But in trauma, we just put 100. So the spine ischemia is not a major issue here, The reason why it does not apply like the same like type B dissection or aneurysms. So in trauma, you just put a small piece 100. So I don't think you can get ischemia from that. So you worry mainly about the hand here. The reason why not everyone do a bypass. Because the hand tolerate ischemia very well if you cover subclavian, except for some scenario we mentioned, like you have dominant left vertebra, you have limma after cabbage. If you have a vertebra coming from the arch because you don't have retrograde flow to the arm because no vertebra in the left arm side, unless you have a good collaterals. This is all relative, of course, or you have an AV axis, on the left arm. But the most important is that if you have dominant left vertebra or you have a limb, I think this is the absolute indication to do subclavian bypass. For the landing zone, the reason why they said bovine arches are good because, as Isam said, because you have a bovine arch, then you have a long landing zone if you have to cover subclavian, which could happen most of the time with a trauma, you cover subclavian as a partially or completely. And not only because you need landing zone, because the curve, you see, because subclavian in the young people, the arch is very curved. So the subclavian come exactly at the curve. So if you put a distal subclavian, sometimes you see the graph is sticking up and you end with the air beak situation. And then you end with a chronic hypertension. So sometimes you have to take the curve and cover subclavian just to take the curve, Now with the new devices like, the GOR, the CTAC, the new one, we able to get rid of these problems, but the old device was very stiff, and we have couple patients end with a chronic hypertension, chronic like scanning to coarctation because of the device sticking out of the arch. So this is something you have to think about it also. So acute angulated aortic arch is that sign. For the landing zone, 2 centimeters, but 1 centimeter is enough. Because remember, here with a trauma, you just need to support the aorta. We're not looking for endoleak like aneurysm. You know, you worry about endoleak and endoleak. Here, you just need to support the aorta and the area of the dissection. So most of the studies showed 1 centimeter is more than enough. Not more, but it's okay, 1 to 2 centimeters. Even some studies showed 5 millimeters is enough. But I think this is too. So I think 1 to 2 centimeters is acceptable. All right, anybody question? Anybody want to add anything? Oh, we're getting late, that's good. Let's keep going. Who is that? Sam?
Yes, sir. It was felt that her thoracic aorta was anatomically suitable for endovascular stent repair. There was an appropriate stent available in the hospital, consignment to use for the procedure. Her condition was much better and her hemodynamics had returned to within normal limits with the use of inotropic support. The vascular surgeon requested that her systolic blood pressure be kept at approximately 100. She underwent successful endovascular stent repair of her transected thoracic aorta. Figure 16.6.
We saw the one you saw before, right? The type 3 injury. You saw that.
Yeah. And
was it again? Okay.
And was transferred to the intensive care unit. After a prolonged hospital stay, she returned home and finally achieved independent living.
Okay, this is the stand they put it here, so they solve it. So what's the question now?
Okay.
Sorry, just take some
Which stent
time.
is that? Is that a Cook or which stent is that? Oh, no, that's
I know, it's going too fast. Sorry, guys.
yeah.
Here we are. Went too fast. Okay. 6, 7. All right, here we are. Which one? Yeah, I think Cook or Medtronics. No, it doesn't look like Medtronic. Yeah, I think Cook or
Looks
Medtronic.
like Cook. That's the Medtronic, isn't it?
Oh, yeah. Okay, so in this shot, she was entered into endovascular aortic stent surveillance.
Okay, program.
We answered 7. Yeah, sorry. So the question now is surveillance. This is a very important question.
Yeah.
8. Which is the following potential complications thoracic endovascular stent repair?
Which of the following are potential complications of thoracic aortic endovascular repair? Okay, A, stroke. Stroke, yeah, it's one of the possible complications, especially if we cover the partial coverage of subclavian. Aortic rupture, also, it's one of the complications if we oversized the stent. Paraplegia is unlikely because, as you mentioned, that we cover only 10 centimeters. However, it's possible also, but it's unlikely. Aortic thrombosis, it's unlikely also. Graft enfolding happened if we oversized. Graft collapse, I'm not sure. A graft collapse.
Okay, sir.
So we can choose many options.
Yeah, many. Yeah.
Yeah, stroke, aortic rupture. Yeah, these are the most common. The others are less likely.
Okay, they said potential, and they said the most common VESAP. So potential. So potential, that means all of them, because potential, not the most common. The stroke, it doesn't happen from, as you said, from coming subclavian. No, it happened from embolization, from air emboli, or if it's an old guy, you get like, emboli from the wire and device, from atheroma, from the arch. I don't think cover subclavian, unless if you have dominant left vertebra, you cover subclavian completely.
Okay.
Aortic rupture could happen, especially if you're ballooning. That's why we don't balloon. Or if you don't use a super stiff wire. If you use a soft wire, try to push the device over the curve, and you don't have a very stiff wire, I saw one case aortic rupture. So you have to be careful. Paraplegia could happen, even especially in old people, they have multiple surgery before. So this is something you have to talk to the patient about him. It's rare, but could happen. Aortic thrombosis could happen. Graft enfolding could happen if you have an oversize. Especially with the old devices, and the graft collapse is the same, like enfolding, so it can happen also. So all of this could happen, so you have to put them back in your mind. But now with the new devices, most of this complication now is less. Yeah. Okay, I have a main question really before, because the last question, guys, which is important. For this patient, when should we do a TVAR? Should we do it immediately when he came, after 1 day, after 1 week, after a month? When should we do this TVAR? This guy, this lady with a trauma. Should be the same day, because remember, we took her, we opened her belly, we back her, we control his bleeding. What about TVAR? When should we do it?
Yeah, and the same admission, not the next day, because we are going to give heparin therapeutic dose, and there is risk of bleeding. So it's not recommended to do it immediately, unless the patient.
Because of heparin, you want to give heparin, but when you do the procedure, you give heparin, right?
Yeah.
So why you worry about heparin?
If the patient had bleeding and already post-laparotomy packing.
But you're not afraid that may ruptures, or if you wait till next day?
Yeah. If the depends on the grade of.
We're talking about this patient, grade 3.
Yeah.
Well, let's go back to say grade. How would you treat grade 1? And is it TVAR or conservative? Anybody else, guys? Doesn't have to be VESAP. Anybody, guys? Please answer. Grade 1. How would you treat grade 1?
Grade 1.
Conservative most of the time.
Conservative. Okay. Grade 2. Grade 2, you have only hematoma on the wall.
According to the extent.
Sorry?
According to its extent, it's mainly conservative treatment, but if it's progressing to a dissection or making malperfusion.
Ahmed, you are in the exam. I'm telling you grade 2. Grade 2 is well defined. Is a trauma. We're not talking about aortic dissection, it's about traumatic aortic transection. See a differentiate.
Conservative treatment and the surveillance of serial CT for progression of the hematoma.
So conservative management, correct? Okay. What about grade 4?
Urgent.
Urgent or immediate?
Immediate.
Okay. What about grade 3?
We can it may withhold 1 day to make sure that the abdomen is no more bleeding from the abdomen, but we don't delay.
So should we do it like a patient came in the morning, you open her belly, you pack her, you're done now, she's hemodynamically stable, take her right away in the same, you're in the OR, you already have the device there, you go and put it there?
I think the next day. I think the next day is more reasonable.
Do we have any data?
No.
No, we have a data.
I think.
Yeah, we have data. No, we have data.
Big data. A lot of data.
Yeah. We're not going to tell you. We're going to ask you to go and research.
That's a good idea.
Recent publications on this issue. There's some very good papers from, we'll give you a hint, to the Journal of Vascular Surgery. Yeah. Yeah,
guys, it's very important, grade 3, because grade 3 is always a controversy. you know, because 1 and 2 very clear, grade 4 is a grade 3. The question is that when you should do it, you know, immediately, later on, just continue conservative management. With the risk factor, you look for it. So this is something, guys, unique. You look for it or work on it, you know. It's a very important. And I'm sure you get a lot of questions in this one. Nobody's going to ask you about something white and black. They always ask you about the gray area. It's like these areas, you know. So you need to look at that, okay?
I think, doctor, in this patient particular, there is two situations. I will need to prevent bleeding and delay the TVAR a bit. At the same time, I need to higher the blood pressure for the head injury in case I want to have a good outcome of the head injury. So usually we balance both of this situation, the bleeding part and the head injury part. I think we have to wait like for 2-3 days.
How you balance it?
So in case like the first stage of healing after bleeding, it will be like 48 hours to 72 hours. So I'll balance this, and I will keep the patient in the lower blood pressure measurement, like submissive hypotension. Then I will treat him with TVAR with minimal dose of heparin as I can. Then I'll ask the neurosurgeon to elevate the blood pressure as high as they want.
Which one is more important, the brain or the chest?
No, the brain is important, but I'm afraid that he will bleed.
To the chest. You give priority to the chest. The way you talk, you give priority to the chest.
Because I don't know how much the brain injury he has, how urgent is the brain injury he has.
Well, let's say he has very bad contusions, you know, and they want to raise the blood pressure.
I'll do the
cannot give beta blockers.
Yeah, and I'll make sure that I don't have any source of hemorrhage, and they will do it like the next day if they are urgent to higher the blood pressure.
Mohammed,
so let
me just
go ahead.
Sorry, Mohammed, let me just intervene a bit here. Okay, what is the target map for a patient with traumatic brain injury?
They want it above 90, doctor. Above 70, sorry. 98, 70, up to them. It's usually 90.
You need to know what they are basing this on. The target map for a severe traumatic brain injury is a map of 90.
Yeah.
Okay, all right. Is a map of 90 a problem for you with the patient with a grade 3 blunt thoracic injury? What evidence do you have that you need to lower blood pressure in grade 3 blunt thoracic injury?
All the aortic injury, I know that I have to put the blood pressure on the lower side. I don't have
you're
the
thinking
exact.
the
aortic.
No, you're thinking aortic.
Dissection.
Ismail, you're thinking of aortic dissection, okay? Yeah. Spontaneous aortic dissection, which is as a consequence of hypertension. Okay, so you've extrapolated that evidence into a trauma situation. If you look at the literature, there's actually no mixed evidence that lowering blood pressure in traumatic blunt aortic injury makes a difference. Yeah. So I'm very happy to live with a map of 90 for a thoracic blunt aortic injury. Yeah. Whereas I wouldn't be for a dissection. Okay, because it's a different pathophysiology.
Yes.
I think you need to be careful. I had this discussion with one of my colleagues last week. We had a case like this, and he wanted to take it quickly, and exactly the same logic that you've just put forward. And we had a long discussion about it. So the traumatic brain injury, yes, they need a map of 90. They don't want it much higher than 90 because if there's contusion, they can bleed into the brain. And you can live with 90. Yeah, 90, and it means 120 over 80 is 90. yeah, or 130, you can live with that.
Yeah.
You don't want him hypertensive, but that is normotensive. But the timing of it is it's an interesting question. If you have multiple injuries like this patient, grade 3, you don't have to rush. Stabilize the patient, correct the physiology, get it ready. If it takes you a day or 2 or 3, that's okay. If there is no other injury and the patient is otherwise fine and grade 3, do not delay for no reason.
Yeah.
Okay. That's, I think, and when you go and read the papers, you'll see the difference in approach and its effect on outcomes.
Yeah.
Okay, Sam. Thank you, Sam. I just want to do a small comment here. The question, I know somebody has seen, he said TEVAR is ideal for older or severely injured patient. Open repair is an important alternative for young patient. No, it's not correct. So the guideline is very easy, very clear. With a patient, unstable patient, with multiple trauma, even young people, I think TEVAR is our best choice, because kind of damage control, as Sam said. So TEVAR is the first option, unless he doesn't have normal anatomy or something, make it unfavorable for TEVAR. But even young people, for transection, TEVAR is better than surgery. And a lot of paper showed that. They did not do any prospective study because they found it's unethical to get patients for this kind of study, young people, to open them and put them through all this risk of surgery, where you can do it very easy with a TEVAR. And second thing is that when you do an open, you have to put a lateral position, which is very difficult with multiple trauma, with a liver laceration. Sometimes spine has spine fractures, they have neck fractures. It's very, very hard to do an open. So don't go with this false impression that open is better for young people. Even young people's transection, TEVAR is the first choice. Correct, Isam and Ali?
Yeah, I agree with you.
Yeah,
absolutely. Yeah, absolutely.
Second thing for timing, guys, study showed, I'm going to give you the hint because just to correct information, that first 24 hours, your mortality go about 9.8%. If you do it after 24 hours, it go down to 4.4%. So if you can delay at least 24 hours at least, because the most you do it in the first 24 hours, this is your high mortality. So you need to delay it at least more than 24 hours. When you do it, the more you delay is better, I think, unless you have an urgent situation. I agree with you, Muhammad. If you have to perfuse the brain, you need high pressure, you should not rush for it, but I think it makes you urgent, but doesn't have to be like an emergency. I think I will do it earlier, but it doesn't mean that you have to do it same day or next day. Because as Isam said, 90 is acceptable, but I don't want him to be on 90 for a long time. So maybe the moment he becomes stable, maybe second, third, fourth day, I'll do a TEVAR, just make me feel more comfortable, But I think that's all what we have to say about this subject. Let's go to the last questions, how we can follow up these patients. The most important questions. I'm sorry, what happened here? You see guys my screen yet, or I'm lost it? Oh shit.
It came and then you lose it. Now we've lost it.
Yeah, I lost it because I did something. I know what I did. I did something wrong.
It says,
anyway, so the last question is how we screen this patient. Do we do an angiogram? Here we are. Or CT, chest X-ray, CT angiogram, intravenous ultrasound, or echo? How we follow up this kind of patients? I know when it's become too big.
I don't know if Farah's still there. Maybe you see us out with this question, Farah.
I know. Here we are. Okay. So what the best way to do it? Muhammad, you want to answer this one? How you follow up this patient? CT scan or chest X-ray?
Yes, doctor. It's a CT scan every year for 5 years, then chest X-ray every year.
Yes, but we have no strong data or guidelines, but at least you need CAT scan for first, I think, year or two until you be sure that your device is fine and everything is healed. But after that, some people do chest X-ray as a seed every year and maybe CAT scan every couple of years. But there's no guidelines really. Right, Isam? Ali?
Yeah, I don't know the correct answer to this question.
Yeah, nobody knows the correct answer. You're right.
Yeah,
Yeah.
I mean, we scan them every year if we can get them.
Yeah.
But 19-year-olds don't like to come back for a CT every year. So we lose a lot to
And they
follow.
don't come anyway. You lose them. Most especially you lose them to follow up because they are young, you know. So they do not come anyway. So, and we don't know what's the long-term follow-up with this patient. We don't know after 30, 40 years what happened with this TVAR, you know. I have to go one time and take one of the TVAR on a young patient because he had it like 2010, but the device was large, so he has complete collapse of the device, and he ended with a chronic hypertension. And I treat him for 10 years, and then he gets fed up. I mean, we can't control his blood pressure. So you have to go and replace his descending aorta, and it's not an easy surgery, I'm telling you. I thought that you can open the aorta and take the graft out. You cannot. You have to replace the aorta because the graft becomes part of the aorta. So really, you have to replace the whole descending aorta. So that's the scenario.
Yeah,
anybody want? Yeah,
it's a difficult question to answer, but I think for the exam, the correct answer would be a thoracic computerized CT tomography. Yeah,
I agree with that. I think someone want to add to thoracic trauma. I think we missed or we
no,
completely.
just general exam technique. I've noticed that most of the candidates are not reading the question properly. They're rushing in without reading the question. So spend the first 30 seconds reading the question. These questions are things like, what are the potential complications of thoracic, aortic, and vascular? There are words planted in there that will affect how you answer. So read the question carefully before you jump into it.
That's true. All right, Ali, anything to add, Ali?
No, thanks.
Okay, guys, I think we covered the trauma. This is a very important subject, you know. And the question is, a heparin, should we give it or not? We have this long discussion, me and Isam before, even discussion group. It's better to give some heparin, but if you have patient has bleeding, DIC, whatever, and you have to put it because like grade 4, I think you can go without heparin and put the device, the TVAR, because it doesn't take too long, you know. But if you can give some heparin, it's better. But if a patient has intracranial bleeding and you don't want to give heparin, you have to put a TVAR. I think some people, they do it even without heparin.
Yeah, no, they do.
All right, guys.
Yeah. Doctor, can I ask a question?
Yes, please.
How we deal with anticoagulation with fractured spine or if we have bleeding, intracranial bleeding?
I understand question. How we deal with what?
How we deal with anticoagulation for the device if we put a device, in this case in a spinal fracture, or if it has intracranial bleeding.
Okay, I mean, for a spinal fracture, no problem, because you see, you do TVAR in the supine position, and this is advantage over open repair, because open repair, you have to put it in lateral position. But with a TVAR, he has to be in spine position, so I don't think the vertebral fracture will be an issue. For intracranial bleeding, as I said now, you can do it without heparin. You can go and do a device without heparin. You just have to be quick, you know, or just give a small dose of heparin, localized heparin, very small dose, maybe 1,000 or 2. But if it's complete contraindication, I think you can do it without heparin.
Thanks.
Right. Thank you, guys. And sorry we kept you a bit long today. Enjoy the rest of the day. And thank you, Isam. Thank you, Ali. Thank you for everyone.
Thank you.
Take
Bye,
care.
guys.
Thank you.
Yeah. Bye-bye.
Thank you.